So let's go back for our. So is it clear, or we should mention it again? Okay. Is it clear, or you'd like to mention it again? So this one is the FDG PET-CT, and it's sure that the carcinoid tumor you cannot see here because it is well differentiated.
طلع ايدك ماما.
Okay, someone can mute himself, please. Okay. So back again, and we can see that the gallium dotatate in this case show the somatostatin. Yeah, Amr, and I did it. Yes, I mute everyone. Okay. So you can see that this patient, when he did gallium dotatate, the carcinoid tumor clearly take the uptake, and also you can see the physiological uptake. In this case, in the spleen is normal, in some kidney and some liver is fine. Also in the FDG PET-CT, sometimes, not sometimes, always the brain take high uptake because it is high metabolic tissue, and also some uptake in the different organs, which is normal. Okay. So our differential, as we mentioned, will be what is called desmoid. Okay. And we already mentioned that it have similar tethering appearance, kinking, angulation of the small bowel. Also, maybe you can, is not very common, but put it in your consideration in the exam, that also something called endometriosis. Okay, it can happen, and it can make extrinsic appearance or extrinsic effect on the small bowel. Okay, so let's go to this case. Which is small barium fourth row, small bowel fourth row, okay? And you are in the pelvis. They mentioned that the lumen is narrow with thick straight folds, okay? So you can imagine that there is one pathology here, yeah? And as a surprise for this appearance, it is something called intramural hemorrhage. Is differential, sure, but you can expect that it can be included in differential when you find focal thickening, focal nodular thickening in the small bowel, or fold thickening. Okay, it can be differential with ischemia, vasculitis if it is segmental. If it is diffuse, it can involve everything like edema, eosinophilic enteritis, amyloidosis. I think this differential is more for the MCQ and yeah, it is more for the MCQ and the short question maybe. So what are the causes of intramural hemorrhage? It can be systemic causes like hemophilia, Schneien purpura, ITP, and trauma and vasculitis, and anticoagulant drugs. Let's go to this case, which is one of our differential, what we mentioned, yeah, with the fold thickening, small bowel fold thickening. So you will mention all this, and don't forget, yeah, hypoproteinemia, yeah. So one of the good differential. So this appearance, they mention in the barium that it is what is called, if you imagine that this is the cecum, so with this appearance, you can imagine that it's called cone cecum, exactly, it's cone cecum. And this is characteristic to be Crohn's, yeah. So terminal ileum disease with narrowing and cone of the cecum, Crohn's will be your top of differential. Sure, yeah, that other differential will be TB and adjacent inflammation, which the most common is appendicitis, and also can be diverticulitis, other neoplasms, which is lymphoma, metastasis, and adenocarcinoma. This is one of the common cases in exam. It can come to you short and is very important, and also for FRCR. They like this type of questions. So when you find like this appearance of operation, yeah, you will think about gossypipoma. So you can imagine that there is something here. And also with the appearance of bowel loops, there is retained lab sponge. And in the CT, it have many appearance. Perfect. Nirmin, Abbas, Ala, Marwa, everyone, yes. This typical for gossypipoma or retained sponge when the surgeon forget something in the towel, like towel, missed towel. Okay, another case. Again, the description in the barium, what it could be. Yeah, it could be nodularity in the mucosa, so of the terminal ileum. So this is a terminal ileum nodularity, a differential, sure, but with this appearance, this nodularity, it is something called lymphoid hyperplasia. Nice, Marwa. So it can be normal finding, but also it can be pathology, especially when it is adult. You can present it presented by this small nodules, especially in the ileocecal region and the rectum. Another case, which is another, yeah, let's have a look in this selected image and see what to describe. Yeah, so when you describe like pancreatic serous cystadenoma or mucinous or whatever, so it is a solid lesion or cystic lesion, because this entity is different from this entity. So you should focus first, is it serous, is it, sorry, cystic or solid, right? Is it cystic? So you are going with differential, as you mentioned, mucinous or serous cystadenoma, or IBMT, or the solid, one of that we mentioned now. Yeah, huh? Yeah, tell me. Okay, so if I go and show you this appearance, don't forget also the pseudocyst, because we, yeah, spin, perfect, near me. So spin also can be included. And don't forget also, yeah, it can be pseudocyst. Okay, so if you find this appearance with this enhancing septation, this is more specific to be, or more with mucinous. Yes, mucinous. With this calcification and enhancing septation, it is more going with mucinous. Let's have a look about what are the types. So the differential will be, yes, let's have a look in this cystic pancreatic lesion. The most important to know, pseudocyst. So don't forget this. This is the most important one. And then you ask or find in the clinical data of this patient if he have previous surgery, previous pancreatitis, any previous, okay? So this is most common or more common than to mention anything else. So pseudocyst, then macrocystic mucinous or microcystic serous, and IBMT, and maybe also cystic islet tumor and spin. Okay, so this is the common. So which one is the grandma and the mother and the daughter? So the serous type is the grandma, right? It happened in the very old age. And the mucinous from the M, you can remember that is mother, right? And the IBMT, sorry, maybe the solid. Let's have a look, because I try to, yeah. So contrast enhanced show you microcystic appearance. So which one? This one? Yeah, spin in the daughter. Yes, perfect. Spin in the daughter. Okay. So the serous one is in the grandma, yes, and you can see the microcystic appearance in this case. Even sometimes it look like a solid from the appearance, yes. So this is serous cystadenoma, yeah. And this is good, yeah, illustration. Pseudocyst with the location, also the most common location, the serous like the head. IBMT, search for dilated for the ducts. Either it can happen in the main duct or in side branch, yes. So So the daughter with the pseudopapillary spill, the mother is with mucinous, the grandma with serous type, yes, and sorry, yeah, and here very good illustration also, yeah, about the serous cystadenoma and mucinous and the main IBMT and the side branch. So which one is this one? With appearance like a central scar, which one? The serous type. So when you find this scar, even in MRI, you can have this appearance. Think about the serous type, okay? Again, another illustration, the pancreatic cyst, cystic neoplasm, or it can be pseudocyst when you have cyst. But when you have solid tumor, it is another differential. It is carcinoma and all other aggressive tumors. And also it can islet cell tumor and so on. But here, when you have cystic disease in the pancreas, think about pseudocyst, especially when you have pancreatitis or trauma, and then ask, go in the other scheme, cystic neoplasm, no history. Is it microcystic? So you can think about serous, but look for the connection with the duct. And if it is, then you can think about IBMT and the macrocystic with mucinous. Nice. Yeah, MRCP. So next step will be MRCP, and sometimes they like ERCP, yes. So, for example, this patient, which have pancreatitis, and you can see easily the pseudocyst appearance. Okay, there is one very good article in the let's just write this radiology assistant. I think everyone should have a look. Assistant, yeah, about pancreatitis. Everyone should read this article. Try to Google it, and you will find very useful information. How to differentiate between pseudocyst and what is called wall of necrosis and abscess, and all these terms you should be aware of it, especially in the practice. Okay, again, pseudocyst, yeah, from central pancreatic necrosis. Okay, some very interesting case for this case that it come in the mediastinal. Yeah. Okay. Again, pseudocyst. What happened here? What's the complication? When you find pseudocyst, you should search for complication of pancreatitis. What happened here? No, not Ala. No, yes, pseudoaneurysm. Yeah, and there is, yeah, sure, so, sorry, and there is hemorrhage. Yes, there is spontaneous rupture after the pseudoaneurysm. It rupture and make hemorrhage. So hemorrhage from the pseudoaneurysm rupture. Which artery? Splenic. Yes, splenic artery. So when you find the pseudocyst, search for complication. So you see here, you will find that there is retroperitoneal extension and inflammation beyond the pancreas, beyond the spleen. The spleen, yes, this is the spleen, and you can see the extension down. Again, you can find hemorrhagic pseudocyst. Yeah, another complication. It can also complicate with abscess. Here, when you find cystic appearance, search for the dilatation of the duct. If you find it, then you can think about IBMT. And here, so maybe the MRCP, maybe it will be helpful in this case. So what happened here? Can you describe? Can come to you with short case. IBMT is grandpa. Okay, grandfather. Thank you. Thank you. Yes, Ala. Grandfather disease. Sorry, this one. This one is grandfather disease. So what happened here in this case? Nice. There is a fatty replacement of pancreas. We like it in MCQ and every exam. When you find this, you will ask about history of cystic fibrosis. So one of the important exam question that when you don't find the pancreas, search for it. How to search for it? What is your landmark here? What is the most important landmark here? How to find the pancreas? What is your important landmark here? No. What is this? Yes, perfect. The superior mesenteric artery and superior mesenteric vein. Yes, you can see the splenic, but in the other cuts. But in this case, search for the head. If you don't find the head, search for the body and tail along the splenic. As I agree with you, a splenic vein and arteries, sure. And you will not find anything. Then you can say that it is lipomatous replacement of the whole pancreas, which is characteristic of the of the cystic fibrosis. There is another disease which is not common called Schwarzman-Diamond syndrome. I just know that's diamond, okay? And also chronic pancreatitis. So differential will be chronic pancreatitis. The calcification may help in this case, that if you find calcification, so maybe it is more with the chronic pancreatitis. Let's have a look in this case, and when you find in the stomach this appearance, the next question is it, as we mentioned, is it benign looking ulcer or malignant ulcer? So what is the differential between benign looking ulcer or malignant ulcer? Yeah, benign ulcer like the location. Which location it like? Yeah, it like the lesser curvature. Yes, perfect. And there is folds which to crater edge. Yes. And the projection is behind the wall, beyond the wall. Yes, projection is outside the wall. Nice. Reach the ulcer crater, Marwa. Nice. Regular mucosal fold, regular, perfect. Regular mucosal folds. Rounded or linear position of the ulcer mound. Yeah, there is something called Hampton line, which is very nice from you. Thank you. Yes, Hampton. And important to follow up, which is response for therapy. If it have size reduction after, so you should mention that if go after, for example, 4 to 6 weeks of treatment, then it is beyond, it is benign. Okay. So this is what is called benign gastric ulcer. The malignant, it happened more in the antrum, and you can see amputated, fused club, and there is sure irregular, not regular as we mentioned, and there is shaggy appearance, irregularity, not multiple. Also, there is something called Karman sign. So what is the Karman sign? Let's have. So again, which this one, it is the thin line which traverses the ulcer here, which is called the, yes, Hampton line, perfect. So this one is the Hampton line and the Karman meniscus sign, okay, which is the malignant ulcer, how it looks. So can come to you as short, okay. Let's go more further. Yes. They mentioned that in this patient, he take like drugs. Yes, erosion in the body and antrum. And this, yeah. So erosive gastritis, one of the good differential. How it happen, what are the causes? It can be from drugs like non-steroidal or steroidal or some stress, alcohol, all this, yes. It happened also with, yeah, non-steroidal, okay. It happened also with Crohn's, also abscess ulcers, infectious like cytomegalo, herpes, and candida. So you can find these shallow defects with erosive gastritis. So this is what is called aphthous ulcers, which happen with Crohn's, and this is the differential. You can find this appearance in the, okay. Let's go to very, very important case. Yeah, which is very common in every exam, EDIR, FRCR, in any exam you have. Yeah, perfect. So when you find a small bowel obstruction, you search for triad. What is triad you search for? Perfect. You will search for any lucency here, which is presented over the liver, which present portal gas or pneumopilia. Perfect. And the third one, small bowel obstruction. What is the third one? You search for gallbladder. So what is called? What's called gallbladder? Yes, ileus. Gallstone ileus. Sorry, gallstone ileus. So how it happened? You can see here the lucency over the liver. Nice. And check for small bowel obstruction. If you find a small bowel obstruction, go and search for any pneumatosis or any pneumopilia over the liver. And the third one will be the stone, which is the most difficult one to find. But if you did CT, then you can find. This is very critical in the exam. They can come to you in the short case. They like it so much. So take care. Gallstone ileus, one of the important, yeah, triad of small bowel obstruction, gallstone, and pneumopilia. Yes. Yeah. Scleroderma. Why? This is the high bound appearance. Yes. Yeah. Like this appearance is antimony for scleroderma. Then you can also the pseudocirculation and abnormal folds in the small bowel. So think about scleroderma, which is this is the high bound bowel. The circulation differential will be Crohn's. Okay. In the anti-mesenteric border, yes. Circulation in the anti-mesenteric border, yes. Here, yes. Marwa, nice, nice. Nirmin. Okay. Let's go to the next. Yeah. So which part should be this one? I think it should be duodenum, yes. So there is abrupt here, abrupt change or cutting or the, yeah. And there is dilatation of the duodenum. So this is what's called perfect, Marwa. SMA syndrome, superior mesenteric artery syndrome, when you find the dilatation of duodenum until the level of the superior mesenteric artery. Yeah. Okay. Nice. And there's also nutcracker, but nutcracker, okay, with the left renal vein maybe. Okay. So superior mesenteric artery syndrome, dilatation of duodenum to superior mesenteric artery, and so on. Okay. And they like this one in the exam, which is antimony. When you find the wall of the bowel and you can find something called air, which is in the wall, and they, yeah, pneumatosis. This is what is called pneumatosis. If you did CT, maybe you can find this appearance with pneumopilia. So this means that the air go, and what happened here? Yeah, bowel infarction, yes. Pneumatosis intestinalis, it can happen in the subserosa and submucosa. The most important to mention that from ischemia, yes. So how to differentiate between portal venous gas and pneumopilia? This one, which is, yeah, the portal venous gas, perfect. Yeah, Nisha, perfect. It can reach the periphery, so can periphery from portal periphery, perfect. Yes. So when you find it reach to the periphery, then it is not pneumopilia, it is portal venous gas, as in this case. And you should mention that one of the most important causes the ischemia. Okay. Other causes can be operation, yes, pseudomembranous and idiopathic infection, steroids, Scleroderma, systemic, all these types. It can also can primary, which is benign type. Yes. So the portal venous gas, like the periphery, and make bowel infarction in adult and NEC in kids. Yes, which is very critical, and you should look for air pneumoperitoneum, air in the peritoneum. Yes, pneumoperitoneum, any perforation. It's very, very critical in the kids, NEC. Okay. Other causes, when you find air, okay, penetrating ulcer. So all of this are critical, as you see: acute gastritis, intestinal distension, IBD, recent operation or endoscopy, and catheterization. Okay. What? Sorry. In adult. Okay. Let's go to this case and what the arrow point for here. Filling defect in which artery? Yeah. SMA, perfect. So again, the SMA and this SMD. So you can see clearly that there is embolus here and SMA, and this is very critical. Okay. Ischemic, it can cause ischemic colitis, yes. So this patient did single contrast barium enema, and there is one rare appearance with this gas collection in the left side colon, in the left colon, yes, what is called Pneumatosis coli, which is intramural air in the colon, yes, and it is discovered incidentally, yes. When it is rounded, so this is more common with, yeah, when it is rounded, it is to be Pneumatosis intestinalis or Cystoides coli, yes. It is like a cyst-like appearance, okay? This patient, they say that's associated with collagen vascular disorders, maybe ischemia, maybe diabetes, but it happened incidentally, and you can find this gas appearance, okay? Something to know. Yeah, this when you read in the textbook, you will find something like about the jejunum and the ileum. So what happened for the jejunum and what happened for the ileum? So this is a celiac disease, perfect. So this celiac disease, the patient is have sensitivity to the gluten, right? And he presents clinically by malabsorption, steatorrhea, and diarrhea. So this is what happened, reversal. So the jejunum should be here. So this is the jejunum, but it looked like the ileum, and this is the ileum, but look like the jejunum. So this is the reversal. And also you can see some dilatation, small bowel dilatation. And if this patient have barium, it make folliculation, right? Yeah. So what happened here, that the folds, that the folds in the ileum, it is increased. Yes. And this patient may be present with transient intussusceptions. Another appearance, and this is the celiac disease. Also in the MCQ, they like to mention that the lymphoma and carcinoma are more common to happen with celiac disease. So what is the differential of a small bowel obstruction without fold thickening? It can be mechanical or paralytic areas. It can be scleroderma or celiac disease. So you don't find fold thickening at this case, celiac disease, but it have characteristic appearance. And we mentioned scleroderma before, and paralytic ileus and mechanical. Okay, let's go to this case, which is very important in the exam again. If I mentioned to you that this patient have already ulcerative colitis, as you see that the haustral better in this patient is lost, yes. So this patient chronic ulcerative colitis. So the most important next thinking of you to think about toxic megacolon. So when you don't find the haustral pattern, directly think about toxic megacolon. So please, when you don't find the haustral pattern and you think about ulcerative colitis, think about the complication which is toxic megacolon. Why? Because it's much more critical than ulcerative itself. So when you find this marked dilatation and thickening of the transverse colon, okay, and as you see there is no haustral pattern, the haustration is lost, so this patient is going to die. Why? Because he have toxic megacolon. Okay, so this is what is called fulminant idiopathic bowel disease. It can happen with ulcerative colitis, but it can happen also with infective or ischemic colitis. We mentioned infective colitis like cytomegalo, all other types of infective colitis, ischemic colitis we mentioned, and there is also something called pseudomembranous colitis. So please, when you find this, go to the next step and search for any free air, because if this patient go for perforation, then he will die soon. So go and search for any air under the diaphragm, any air, free air in the peritoneum. Okay? Don't forget this. Ulcerative colitis, loss of haustration, toxic megacolon, then free air. So put your scheme in this case. Okay? This is what we mentioned already. One of the most important cases, again, in the colon, when you find this appearance, yeah, it is
cecal volvulus.
Perfect. Thank you for your sharing. Yes, this is a volvulus. Which type of volvulus you would like to say? Then you will go to the famous, the differentiation between, is it cecal volvulus or sigmoid? What I suggest you to do, that to look for the site of the cecum and the site of sigmoid. So if you find, is easily to find that the sigmoid is in its place. If you find the sigmoid in its place, so perfect, it will be the cecal one. If you don't find it, so it will be the sigmoid one. They mentioned in the textbook that look for the apex of the dilated, right? When it is go to the left, which one it will be? The cecal, Nirmin, yes. The cecal, which is directed to the left side. When it is directed to the right side, it is the sigmoid. And they mention many differentiation, yes. Also, they mention, as you mean, yeah, perfect, Ala, that the haustral more with the cecal and the left side more is a haustral. Okay. But to be honest, when it is very, very dilated, they look very similar. So what I suggest you to do, try to see the right iliac fossa and left iliac fossa and trace if there is sigmoid or there is cecal. And if you find one, then the other one will be the pathology. And also the rule of the direction, it can help you. And
cecal volvulus can direct any part of the abdomen, while sigmoid volvulus usually will apex on the right side.
Yes, yes. So the cecal in the left side and the sigmoid in the right side. Perfect. Okay. And also, as Ines will mention, that the sigmoid is like to the coffee bean appearance. So imagine that maybe this one is like a coffee bean when you take your morning breakfast, and the cecal is like the sigmoid, the coffee bean, and the cecal, which is this one, is the embryo-like. So this one, you can imagine that it looks like embryo fetus, and the sigmoid, it's like your coffee bean when you take your breakfast. Okay. Everyone is agreeing with this? But anyway, It is very common in the exam, at least in the MCQ, and they like it also in the short and sometimes in the long. Any exam you will have this appearance, and they like the differentiation, how you can make it. Let's go to another case.
ERCP.
This is ERCP, right? And I hope that this is clear. I know that is not very clear, but no, it is not.
Divisum? Divisum?
Yeah, it is pancreatic divisum. Yes, which is a congenital anomaly. So they describe that that there is opacification of the ventral pancreatic duct, but the other duct is very small and short. Okay, let's have a look what is the pancreatic divisum. As you know that there is two ducts, which is dorsal duct and ventral duct. Yeah, and failure of fusion of the dorsal and ventral duct give you this what is called pancreatic divisum. Okay, and the dorsal duct drains in the body anterior and superior portion. Yes, in the minor papilla, and the ventral duct, which is the drains in the major papilla. Okay, if the major papilla cannulated, only ventral duct will fill. The dorsal duct will not appear. And the MRCP, maybe sometimes it's more easy. As you see here, that there is faint ventral duct, okay, with pancreatic divisum configuration. Okay? Yeah, okay, I agree with you. Ventral, opacified, and cross sign. Okay. Let's have a look in this case, which they like it in the exam as hepatic focal lesion differentiation. So when you find this, yeah, you will go. Yeah, you will go to mention that it is FNH, and yeah, FNH of the important differentiation, central scar. Then the next question will be how differentiate it from the fibrolamellar HSC as a common entity and diagnosis. So, yeah, which one is in the T2 will be bright? In the T2, which scar will be very bright in T2? Yeah, FNH, perfect. And which one have delayed enhancement of the scar in the contrast?
Focal nodular.
FNH, perfect. So this is the most two things, and they like it in the MCQ, and they mention it. In the non-contrast, it looks like a hypodense. Sure, that is important to know that it's tumor with Kupffer cells, and there is something called now specific contrast, and it can be helpful in such cases. In the contrast enhances CT, it takes intense uptake, as you mentioned, except the scar which retain the contrast. Sometimes in the angio, if it make angio, you have this appearance which is called spoke wheel appearance, which is intense. Yeah. Yes, EvoVest contrast. Yes. Okay. Thank you. So this one of the special contrast that used to as this tumor only liver tumor with Kupffer cells. So this is good that you can know and you can differentiate when it is very difficult to differentiate between both. Again, in MRI, yes, focal nodular hyperplasia, and as you mentioned, delayed enhancement. So, what do you think about this one? And why?
Fibrolamellar carcinoma.
Yeah, it takes the left side of the liver, and as you see, there is lesion, which is exophytic lesion. So one of the important terms here that you mentioned, this, and no enhancement delayed. In the case of the scar, it doesn't retain the contrast, and
more large in size, heterogeneous.
Yeah, and what else?
And sometimes you